It's my job to introduce our guest speaker, Dr. Field Willingham, who is the Director of Endoscopy at Emory. He's also Associate Professor of Medicine in the Division of Digestive Diseases at Emory University School of Medicine. So today we'll have several presentations followed by a poster event in the lobby, I believe, outside. So everyone please attend not only obviously this session, but the posters as well. So Field is a leading expert in endoscopy, and I've gotten to know Field in a better way recently in terms of some of the changes that have gone on in digestive diseases. He is certainly an international leader in interventional and therapeutic endoscopy. And as I mentioned, is director of our endoscopy program. He has been practicing at Emory Healthcare since 2009. He is certified in both gastroenterology and internal medicine and does a variety of challenging endoscopy procedures at our institution. He was named in 2016 president of the Georgia Gastroenterology and Endoscopy Society. Field has a master's degree from Johns Hopkins University. He attended University of Maryland School of Medicine and completed his residency at Baylor. He then went to Harvard for GI training at both Harvard and Mass General Hospital. Completed his fellowship at Advanced Therapeutic Endoscopy at Harvard Medical School, again in association with Massachusetts General Hospital and also Brigham and Women's Hospital. So he is, from a research perspective, an outstanding clinical researcher in the area of new interventional endoscopy, clinical trials in this particular space. We have an outstanding unit of endoscopy, interventional endoscopy here at Emory, an outstanding program in that regard. And he's pioneered a number of therapeutic endoscopy procedures, especially in the area of cancer and cancer-related malignancies of the GI tract. He has a number of awards, and I mentioned a couple already, many outstanding awards for both his research as well as his education, his commitment to education. So it's with great pleasure that I welcome Dr. Willingham to give the opening remarks for Research Day.
Wow, thank you so much. I did not know that was coming. Thank you. Really a very kind introduction. It's a real honor and pleasure for me to be here today. Really one of the great honors of my career. I love to do research with all of you. I've had the great privilege of being involved with many of the brilliant residents at Emory. And so I just wanted to talk about some of that with you today. Everything I'm going to talk about today was done with Emory residents, and so you'll see some of the brilliant and beautiful projects that they've done. I just wanted to start with a quote. So in the fields of observation, chance favors only the prepared mind, or you may have heard this as chance favors the prepared mind. Anybody know who said this? Somebody's got to know. This has got to have come up on Medical Jeopardy, something, right? Nobody? So this was Louis Pasteur. This quote kind of resonates as I'm trying to think of, projects for residents and, what might be a good topic for a resident to do research on. And so I'm going to go over some of those projects with you today. Another quote from Louis Pasteur is let me tell you the secret that has led me to my goal. My strength lies solely in my tenacity. And so if I had to identify one quality of the most successful residents, it's not, just sheer brilliance or being chief or anything. I would say really it is tenacity. And so if I have to leave you with one pearl, and Karen asked me to talk about things, successful qualities in residents that would lead to research projects, I would say probably tenacity. These are the other things that, the other pearls that I came up with is, I was thinking about things that residents do that leads to great projects. So go by early, be tenacious, in person often helps, own your own research project, keep track of your dates and deadlines, look for iterations of your work. So if you've done one project, see where the next project in that same vein can take you. Don't get discouraged. A dear friend of mine who was in med school a long time ago said, if I'm not getting a certain number of rejections, then it means I haven't extended myself far enough. And so he had sort of really turned, none of us like rejection, right? But he had kind of turned that on its head and said, if I'm not getting a fair number of rejections on a routine basis, I haven't really stretched myself. So, think about that as you're considering your research and your careers, and then ultimately find something you're passionate about. So, that's my whole talk. Residents like high yield, so that's really it. But we'll go through some things together. So this is, of course, the endoscopic appearance of Barrett's esophagus, right? And this is something that we see a lot in interventional endoscopy. What is this? Any thoughts? Everybody see this little small mass right here? See if I can get my cursor. So here's a mass right here, right? So this is an intramucosal adenocarcinoma arising in Barrett's esophagus. This is a very early tumor, and this is what we treat a lot of endoscopically. This is a much more advanced tumor. This is a T3 esophageal cancer, and we may stage this, and in some cases we treat it, and so we'll talk a little bit about that today. And I wanted to share with you guys a very special patient that we saw. So this is a 72-year-old man. He had this history of colectomy for diverticular disease, obesity, and he developed this severe abdominal pain and gets a CT scan of the abdomen, and that revealed nodules in his lungs and diffuse lymphadenopathy. And so they sent him for a biopsy of one of the lymph nodes, and it showed metastatic, moderately to poorly differentiated adenocarcinoma. And he was referred to oncology, and they did some imaging. And so we're going to visit this case a couple times over the course of the presentation. But I just want to kind of give you a little background about esophageal cancers, right? So you may be familiar with this graph. Most people are aware of the trend down in esophageal squamous cell carcinoma and the trend up in esophageal adenocarcinoma. Anybody know why that might be? Why squamous cell carcinoma has decreased over time? Any thoughts? Smoking. Okay. Yes. Great. So as smoking has decreased, the incidence of esophageal squamous cell carcinoma declined. And then we see this trend up in esophageal adenocarcinoma. But this data, the inflection point was around 1996. And this data is really through 2001. And so we had begun to think as the field of endoscopy began changing and many patients with early esophageal cancers were being sent to endoscopy for treatment, we began to wonder, well, what has happened to the incidence of esophageal cancer over recent years, and how much of it was early. And so we decided, well, it should be possible for us to look at this. And so Tina Pham came by, and we embarked on a project, and she really did a beautiful job. And the first thing we did, and I'll just sort of walk you through the project, is we charted the incidence of a whole bunch of different malignancies over time. And so this is the initial graph, and we looked at it, and we kind of scratched our heads and said, well, there's just a lot of different tumors there doing a lot of different things, and I can't really, make too much out of that. But the question that we really had was which tumors are increasing and which tumors are decreasing. And so we took this data and we said, well, we're going to calculate the percent change over time relative to the first year that we have data, so from 1973. And so we graphed that out. So these are all the different malignancies, and these are years on the bottom, and this is the percent change relative to 1973. And when we graphed them out this way, you can see this red line right here. This is esophageal adenocarcinoma. which really paints quite a concerning picture, right? These are all the other major epithelial malignancies down here, which have either declined or have basically remained stable over time. But you can see there's been this dramatic increase in the rate of esophageal adenocarcinoma over time. And so Tina has finished this paper, and this paper is being submitted right now showing the dramatic increase in the rate of esophageal adenocarcinoma over time. And so one of the other things that we were wondering about was, well, how much of this is early? You know, if this is all very advanced cancer and it's not something that we can treat endoscopically, then maybe it's not that relevant. But she was able to go back into the database and pull the data out by stage. And what we found was that about 21% of all this cancer is very early, so T1 or earlier stage. And so all of those patients are really potentially curable by endoscopy or by surgery. And so, this was just a terrific example of, resident research. Tina, learned how to analyze the SEER data, learned how to use the SEER database, and we went through multiple iterations. And, this is her, beautiful graph from her paper showing the 21% of all the tumors should be addressable really by endoscopy. So anybody know why? Why might esophageal adenocarcinoma be increasing? We've said smoking decrease, and we decrease squamous cell carcinoma. What's going on with esophageal adenocarcinoma? Any thoughts? Obesity. Okay, great thought, right? So there's a huge growing problem in our country with obesity, right? It's really reaching epidemic proportions. Really, here it is, particularly in the South. We're seeing just a dramatic increase in the incidence of obesity, right? And so I was working with Zach Spiritos at this time, and we said, well, if that's really the case, we should be able to study that as well, right? And we know it's been published already that in an individual, greater degrees of obesity confer a greater risk of carcinoma. But nobody had really looked at it at the population level. And so, as our whole country is getting more and more obese, we should see a corresponding increase, right, in the incidence of esophageal adenocarcinoma. And so Zach did a brilliant job of going and getting data from the INHANE study on national obesity rates, and then we regressed that against the incidence of esophageal adenocarcinoma. And here is the trend. So the correlation coefficient is 97. It's remarkably tightly correlated, the incidence of esophageal adenocarcinoma and the national prevalence of obesity. So this hasn't been published, so please don't go scoop us and submit this. But Zach will present this at DDW, and we're in the process of submitting his paper showing this. And so, this is the correlation coefficient. We said, well, why don't we, take a look at it by year? And so again, this is the percent change in the annual incidence, what I showed you before for esophageal adenocarcinoma. We also wanted to look at a couple other tumors. We said, well, maybe obesity is contributing to all esophageal cancers, right? Or maybe it's all foregut malignancies. So we said, well, we'll also look at gastric adenocarcinoma and esophageal squamous cell over time. And, so over time, the rate of squamous cell and gastric adenocarcinoma have decreased, while esophageal adenocarcinoma has increased. And then if you graph the national prevalence of obesity over here against the incidence or the percent change in esophageal adenocarcinoma over time, you find that these graphs are almost perfectly overlaid right there, which is concerning. And there's also a biologic plausibility, right? If obesity leads to GERD, and GERD leads to Barrett's esophagus, and Barrett's esophagus leads to adenocarcinoma, you now have a plausible mechanism, and we're also seeing essentially a one-to-one correlation. So this was just a beautiful research project that Zach took on, and And here's the fruits of his project. So I just wanted to go back. Those are some studies that that we've completed, right? But when you get a sort of the little idea or a little concept, how you run with that and turn it into a research project. So this is our patient again that I described to you before, and so he gets referred to oncology with this metastatic adenocarcinoma, and this is the note from oncology. They spoke with him. He gets a PET CT that shows an esophageal mass, and they said, this is a treatable but not a curable malignancy. Average life expectancy would be 12 months and 6 without treatment. So they started him on definitive chemoradiation. He initially has a response, but then he has a local recurrence. So they changed the regimen. He did see surgery. They offered him surgical resection, which he declined. And then they sent him to us, and they said, is there anything you guys can do? One of the frequent things that people say is, can you laser that thing? Can you go laser? It's always a laser. I don't know why, but can you go down there and laser that thing? And so we said, well, we don't really laser that, but there may be something we can do. There was this technology that we were looking at or working with. It's cryoablation, and this is allows us to spray liquid nitrogen onto a tumor. And this had really only been used for very superficial cancers, for Barrett's esophagus or very early dysplastic lesions, but not really for advanced tumors. But we said, well, I don't know why it wouldn't work for a more advanced tumor. And so we saw him, and we did an endoscopy, and it was too advanced really to be resected. But we said, if he's not a candidate for surgery, salvage, cryoablation could be considered, but it wouldn't be with curative intent, right? You can tell this is from my note back many years ago. You can tell we were very excited about it, and I'm sure you can tell where this is heading. They said, well, that's great, let's do that. And referred him back to us for cryoablation. And so we kind of embarked on this cryoablation with him, and this is a picture of his tumor that's been frozen by liquid nitrogen here. And, we sort of said, I'm not sure if this is going to do anything for your tumor, if this is going to work. But we started treating him, and he became absolutely convinced that this was keeping him going. He was 100% sure of this. And so he would come back and see us every month or two for cryoablation, right? And this went on for a long time. And, I'll never forget the day I walked in to see him, and he called me Field, and I walked in, and I said, hey, how's it going? You ready to freeze that tumor again? And he said, yes, said, let's do it. And I said, well, how are you doing? And he said, well, I just had my 5th last Thanksgiving. Right? So it's really a profound moment for us. This was about 5 years after his diagnosis. We've been treating him with endoscopic cryoablation. And so, around this time we began to think, well, maybe this is doing something. I had not been totally convinced before, but I thought maybe it is actually having a significant impact. So what is the survival for esophageal adenocarcinoma? So this is the survival curve, and this is distant disease, which he had stage 4, and you can see there's a very low rate of survival at the 2-year mark, right? And but we kept treating him, and we got out to 7 years. And so here's our patient up here at 7 years with metastatic esophageal cancer. This is when Zach shows up again, right? So Zach, we decided, well, we're gonna look at this case. And so Zach wrote this patient up. And here's his publication on long-term survival with stage 4 esophageal adenocarcinoma in combination of chemoradiation and serial cryoablation. And this is his PET scan. So you may be able to see this is the tumor on the PET scan, and this is the tumor on his endoscopy. This is after we began cryoablation. You can see that the PET scan has regressed, and the tumor has also regressed here. And then this is at 7 years. And you see we've kind of lost control of the tumor here. And here's the tumor growing, but this is the lumen of the esophagus. And so the tumor has kind of grown exophytically or out from the esophagus, and he retained his ability to swallow and was not on a feeding tube and did not have a stent for this whole period of time. And so it was really just a remarkable case, and this is what this sort of observation, sort of taking cryo, which was really meant for, or at the time was really felt to be for superficial disease, and trying to apply it to a more advanced tumor, and then where does that lead you? And so that's kind of the, I don't know, a kernel or an inkling that's going to lead to a bigger study. I couldn't resist showing you one more patient. So probably based on that experience, this is a patient that was just referred to us with the same sort of thing, metastatic esophageal cancer that was locally recurrent. And you can see this is a very recent case. So this was from August of 2017. And then here's his scan from March. And this is after about 4 cryoablations. And so I'm just going to march you through his scan. And what you'll begin to see, this is the tumor right here at the G junction before and after. And so I'm marching you through his PET scan there, and you can see that this cryoablation appears just to have melted that tumor away. It was just really remarkable. It was a brand new PET scan. I wasn't even sure if it was going to be repeatable in another patient, but you can see this is another patient that's just had a dramatic response to the cryoablation. And so with that, you may want to see cryoablation, and I just wanted to show you one case. This is Raj Dalsania's case. And so, around this time, we were getting this great response with esophageal adenocarcinoma, and a very ill lady, 77 years old. She's had 4 primary tumors. She's had an esophagogastrectomy already, and she was referred with a new diagnosis of a gastric cancer. And, she had been seen in the Winship, and they said there's no surgery. She's had all the chemo and radiation that she can have. Can you go down and laser it, right? So anybody can go laser it. And so I said, well, I don't think we can laser it, but and cryotherapy has never been reported for gastric cancer. But we said, well, perhaps I don't know why it wouldn't work for gastric, and so we after a lot of discussion decided that we would offer it to her. So this is her endoscopic ultrasound here, and you can see she has a 19 millimeter mass in the stomach, and I'm going to show you, this is the lesion right here, and I'll show you, this is her initial EGD, and you can see this is the tumor right here in the pylorus, and here's a still image of it. And so we're going to treat this with cryoablation now. So there's a cap on the end of the endoscope, and this is the cryotherapy catheter. And we're just going to begin spraying this with liquid nitrogen. And you can see the tumor begins to freeze here. And this is a good freeze. We're going to get a nice treatment effect on this tumor. And then she comes back 2 months later, and we were very surprised. Now here's the tumor. So it's been a fairly dramatic response, even just to one round of cryoablation. And we said, we're going to treat it again. This is a decompression tube that you use during the procedure, and we're again freezing the tumor here. And we get another good treatment effect on it. And around this time, it became time to write up our work for DDW. And so we bring her back. This is 2 months later. You can see the tumor's essentially gone. There was this little flat spot that we were not sure about. and we biopsied that spot, and there was residual gastric adenocarcinoma there, unfortunately. So Raj, wrote this up and submitted this, and it was accepted. But the really amazing thing, this patient just came back in September of last year, and this is her follow-up endoscopy after one more round of ablation, and you can see the tumor now is totally gone. That little red spot is where the tumor used to be. And we did a bunch of biopsies at that spot, and they all came back as negative for any cancer. Here's the path report, just acute and chronic inflammation. They said patient's history of gastric cancer and cryo is noted, and multiple levels were examined and were negative, and they did the corresponding immunostains, and there was no evidence of a residual carcinoma. So now Raj is probably going to write that up, and these are the sorts of cases that I think will lead to projects and studies down the road. So go by early, be tenacious. Sometimes showing up in person with somebody you want to work with is a great way to get involved with a research project. Own your own research. As I mentioned, Tina and Zach, they sort of went out and got their data and, learned how to use the SEER database, analyze their data, keep track of your dates and deadlines. The dates don't always work out right. We had to submit Raj's project before we had total resolution of the gastric cancer, but that's okay. And now he's going to publish the total resolution. Look for iterations. So, initial study, just looking at the incidence of adenocarcinoma, then correlating it with the prevalence of obesity. It's just an iteration of that work, but very significant. And then don't get discouraged, and I think you're always going to be most successful at something you're passionate about. I am nuts for endoscopy, and so that's what I always study, but find something that you love, and that'll be the thing that you're most productive in. So if you have any questions that can't be answered by Google or Sun Worship, I'd be happy to give it a shot. And thank you again so much for this great honor.
So thank you, Dr. Willingham, not only for this excellent presentation that hopefully really highlights the importance of preparation and tenacity and partnering with our very dedicated faculty here to result in some really wonderful collaborative research projects here at Emory. It's sort of the perfect landscape for us to launch into some of our other oral presentations that we'll be going through in just a minute. So this has been a really great year for our residents in research at Emory. We had 53 residents who presented scholarly work and counting at scientific events, including 3 international meetings, 27 national scientific meetings, and 23 regional meetings. 28 of these projects were case reports, and I'd like to announce that the winners of our case report competition this year were, in no particular order, Nick Scanlon, who's an intern in our program, who had a well-written case report on ANCA-positive vasculitis with glomerulonephritis as a cause of urticaria, resolving with rituximab, my kind case report. And then also Casey Graziani, a PGY3 in our program, with a case report on acute cor pulmonale and cardiovascular collapse following illicit cosmetic silicone injections. And then finally, Tiffany Dong, another intern in our program, with osteomyelitis of the first cervical vertebrae. So the winners of the case report, the abstracts of the winners of the case reports, as well as the other case reports that were submitted, are all in packets outside of the auditorium for all of you guys to review when you're reviewing the poster presentations. We had 25 original research presentations at national meetings this year, and of the residents who submitted their work for evaluation at Resident Research Day, there were 3 that were selected for presentation to the wider audience today. And I'm so pleased to announce them today for them to share their work with you. And so before we get into that, I just want to hit a couple of thank yous to make sure that everyone receives appropriate acknowledgement. So first, thank you to Spencer Maddox, who's the chief resident who really spearheaded this effort, along with Thetis Carries. Especially the residents in this program know that, her working with us on these types of projects is really a labor of love. So I really appreciate their leadership and organizational support. We had wonderful judges for our original research presentations. That includes Joanna Bonsall from Hospital Medicine, Noble Malik from Hospital Medicine, also an APD here, and then Mayor Modi and Andrew McHugh as our chief resident representatives. And then as judges for the case reports, we had Munish Luthra of Pulmonary Critical Care Medicine, and also Dustin Smith as our APD and Hospital Medicine judge as well. So thank you to them. And then for the abstracts of the original research that we want to highlight today, first, I'm so excited to introduce Nithin Gopalsamy, who will be presenting Pulmonary Embolism in Sickle Cell Disease, a retrospective analysis of the use and yield of radiographic studies. And I think, do I navigate to his presentation? I do. Okay. I can just... Hold on just a minute while we work out some AV stuff.
Are you still running off the laptop? Or
I have disconnected and then we have it up on the source.
So you're going over to this one?
Yes.
Okay.
Okay, 2 seconds.
Hello, everyone. My name is Nithin Gopalsamy. I'm one of the PGY2s in internal medicine here at Emory. And like Dr. Law said, I'm going to be talking to you about pulmonary embolism in sickle cell disease. So first, just looking at venous thromboembolism, or VTE in general. It's a well-known complication of sickle cell disease. One study found that looking at African-American patients with sickle cell disease, there's a significantly higher rate of having a PE compared to African-American cohort without sickle cell. And both African-American patients with and without sickle cell disease have a high rate of DVT. This is another study showing the cumulative incidence of VTE over the course of by age. This solid red line is looking at patients with sickle cell disease who have frequent hospitalizations, so more than 3 times a year. And they have a higher rate of VTE compared to this dashed red line, which is asthma patients who have frequent hospitalizations, compared to the solid blue line, which is sickle cell patients who come to the hospital less often, and asthmatics who come to the hospital less often. So there seems to be an association between sickle cell and the incidence of VTE. When you look at pulmonary embolism in particular, it's associated with increased mortality among the sickle cell population. So I think for providers, that often raises our index of suspicion for PE when we're treating these patients. But what I would argue, and what we looked at in our study, is whether this has gone too far, whether we're imaging too many people, whether we're looking for PE too often. So this is a study looking at the general population, and what this graph shows here is that after the CT pulmonary angiography study, or the CT-PE study, was introduced in 1998, there was an increase in incidence of diagnoses in general. There's an increase in incidence of us finding PEs as well. However, as you can see from this relatively flat line at the bottom, the mortality didn't really change. So the question is, are we really finding clinically significant diagnoses in these patients? Then, of course, any study that's looking at imaging, we always worry about the risk of radiation. Particularly with CT scans, there's just generally thought to be a higher dose of radiation associated compared to their plain film counterparts. I think this is more relevant in the sickle cell population, where a lot of these patients are younger when they're getting imaged, and are often getting imaged several times a year. And then a risk that's unique to PE is, what do you do once you diagnose them? The treatment itself certainly isn't benign. Again, looking at that same study, after the CT-PE was introduced in 98, we see an increase in complications associated with treating the PE, namely anticoagulation. So there's a higher rate of GI bleeds, there's more thrombocytopenia there we see, and then there's a slightly increased incidence of head bleeds. So then the question is, who exactly do you image? Certainly, there have been many studies both in medicine and in emergency medicine trying to risk stratify these patients, trying to find out who we should be more appropriately imaging. You may be familiar with some of these criteria that we look at. I'm not sure my phone's going off. One is the Geneva score. This is just the criteria that's mentioned within that. Another is the PE rule-out criteria, or the PERC score. And I think the one we may be most familiar with is the Wells criteria. And what I would argue within sickle cell disease is that it's more complicated. What I've highlighted here is just across these different algorithms, what I think right off the bat is going to be positive for most of these sickle cell patients. I think most of them, when we see them, especially in an acute setting, they're going to be tachycardic. Either they're in pain or they're just acutely ill. Many of them are hypoxic. Certainly those who are in crises are going to have pain when you palpate their limbs. And a lot of them may have hemoptysis. So if you just go by these algorithms, you might just end up imaging everybody. And then the other complication is that not all sickle cell patients are the same. If you look at those with SS disease, I think they're the ones we often think of as being sicker, and they are more likely to have vaso-occlusive crisis or acute chest, but studies have shown that VTE is actually more common in the SC and the sickle beta thalassemia populations. But there's been little data quantitatively comparing the incidence of VTE by hemoglobin sickle cell phenotype, and that's what we focused on in our study. So our hypothesis going off was twofold. One is that we thought there'd be a low diagnostic yield for PE across all these sickle cell patients, especially we thought with the SS population. We felt that they're more likely to be imaged and we might find less PEs in this population. We also then looked at markers of hemolysis between patients with and without a PE, and we didn't think that there would be a significant difference between them. We thought there'd be hemolysis regardless. So what we did was a retrospective chart review. We looked at 1,127 patients, and we reviewed 3 types of scans, the CTPE study, VQ scans, and non-contrast CT scans. And what I'll note here is we only looked at studies that were explicitly ordered looking for a PE. So we didn't include VQ scans that are ordered, let's say, for a pulmonary hypertension workup, and we didn't look at non-con CT scans that were just looking at the lung parenchyma. Our primary outcome was, again, looking for studies that were positive for PE. And then we also wanted to see if there were other alternative diagnoses that were coming up in these patients who were being looked at for a PE, namely acute chest syndrome and pneumonia. Our secondary outcome, we looked at 2 markers of hemolysis, LDH levels and reticulocyte counts. We initially included D-dimer, but it wasn't actually checked as often because I think providers knew that that wouldn't be as helpful. So we looked at these 2 additional markers. And so what did we find? First of all, there was a slight skew towards female patients. There were 53% of the patients we looked at, with 47% being male. Looking at the age, not surprisingly, they skewed to the younger adult population. Most of them were less than 45 years old, with a significant amount of them being between the age of 25 to 34. When we looked at the phenotype, a majority of these patients did have hemoglobin SS disease, though there was also a significant amount of patients with SC, as well as sickle beta thalassemia, and a slight percentage of people with sickle beta null and other sickle cell variants. When we looked at the studies, most of the studies we looked at were CTPE studies. There were also almost 100 VQ scans, and there was actually 1 non-contrast CT study that was ordered to look for a PE. So when we looked at the patients who were imaged, what we found was that there was patients with hemoglobin SS were significantly more likely to be imaged than those within the other phenotypes. Almost a third of them were imaged. But interestingly enough, when you look at the yield from these studies, patients with SS disease had a PE only 6% of the time. And this is almost a third of what we saw with SC patients, who are significantly higher, significantly more likely to have a PE across the phenotype. And to give you just some perspective, if you look at the general population, the literature varies on the numbers, but it's thought to be between 8 to 20% of the studies that we look for a PE end up being positive. So again, I'd point to the SS population having a yield even lower than what we see with the lower numbers we see from the general population. So when you look at acute chest syndrome as one of the possible alternate presentations, almost a quarter of the patients with SS disease ended up actually being diagnosed with ACS. And this was significantly more often than in the case with SC, sickle beta thalassemia, and sickle beta null. If you combine acute chest and pneumonia, because differentiating these diagnoses is often pretty difficult, again, there's just a high rate across the board of these patients who are imaged for PE actually instead of having a pneumonia or acute chest, with at least 30% regardless of the phenotype. If you then look at the markers for hemolysis, if you start off with LDH, we actually saw a statistically higher rate of LDH in patients who did not have a PE versus those who did. I think one possibility is maybe these patients who didn't have a PE were more likely to be having a true vaso-occlusive crisis, maybe acute chest, and thus had a higher rate, a higher LDH compared to patients who ended up actually just having a PE. If you look at reticulocyte counts, again, it trends towards being higher in patients who did not have a PE versus those who did, though it wasn't statistically significant in this case. So as I wrap up, I just wanted to give you a little bit of context. If you look at between June of 2016 and 2017, there were about 4,100 visits to our Grady Acute Care Center. And plus or minus a couple hundred, this tends to be the case for each year. We've had the EMR for about 10 years, so if you just roughly extrapolate that out for the 10 years, there's been about 41,000 such visits. In the study that we looked at, in total over these 10 years, we found 44 PEs. So if you just do a rough calculation, divide that by the number of visits, only 0.1% of the time do you end up finding a PE. 99.9% of the time it ends up being something else. So my conclusions. So one is that I think the incidence of PE is more nuanced within the sickle cell population. I think they have a lot of alternate causes for what they present with, especially if it's pulmonary or cardiovascular symptoms, most notably acute chest syndrome, but also they could just have a pneumonia. But I think within the SC population, in my practice, I would probably still have a high index of suspicion for them. The 17% yield is comparable to some of the higher numbers I found in the literature for the general population. But with SS patients, though oftentimes they are indeed sicker, I would tend to keep my differential broader. I would still think about acute chest. I would still think about other causes for why they're coming to you instead of a PE, especially and oftentimes in these patients, they've been imaged 5 or more times in their lifetime. So again, as often in medicine, I'd keep the differential broad. I'd like to thank Dr. McLemore and Dr. El Rossi for their guidance and mentorship, and thank you guys for having me.
All right, thank you, Nithin. And in the interest of time, we still have 2 additional really great presentations, so we're going to keep moving, and then we'll do questions at the end. So next up, we have Demetria Smith. She's a PGY3 in our program. She's moving on to Hematology Oncology Fellowship at MD Anderson. And she's here to present her research on patterns of BRCA testing at a safety net compared to a university hospital.
Thank you very much for coming. My project is entitled Patterns of BRCA Testing at a Safety Net Compared to a University Hospital. I have no disclosures to report. So as we all know, breast cancer is very common and it has a very high mortality rate in this country. There have been over 250,000 new cases and over 41,000 deaths last year alone. And 5 to 10% of women who are diagnosed with breast cancer will test positive for a BRCA mutation. BRCA1 and BRCA2 are autosomal dominant tumor suppressor genes that together account for about 30% of heritable breast cancer. And the lifetime breast cancer risk for a woman who is BRCA positive is 60 to 70%. There's a 5 to 10% risk of BRCA mutation in women who are diagnosed with breast cancer. And while many people are aware of the increased incidence of BRCA mutations among women of Ashkenazi Jewish descent, studies have also shown an increased risk among Hispanic women, women who are diagnosed at an early age, women with positive family history, and women with triple-negative breast cancer. Black women in the U.S. are more likely to be diagnosed with breast cancer at an early age compared to their white counterparts. They're more likely to be diagnosed with triple-negative breast cancer, and they're more likely to die from breast cancer at any age. However, the exact prevalence of the BRCA mutation among Black women is currently unknown, and that's largely in part due to the low testing rate among Black women. So the genetic testing company Myriad patented the BRCA1 and BRCA2 genes in the mid-1990s, but in 2013, the Supreme Court ruled that patenting of any human genes was illegal. So even though the cost of BRCA testing and genetic testing in general has decreased in recent years, it can still be cost prohibitive. So a single gene assessment may range from $400 to $500, whereas full sequencing may be upwards of $3,000. And while there is some genetic counseling and genetic testing that is covered by the Affordable Care Act under the umbrella of preventative care, often the insurance companies are using different criteria than the evidence-based criteria that many clinicians would use to determine who needs testing. Currently, BRCA testing has implications for prevention of future cancers, screening of family members, and treatment, as we now have drugs that are targeting BRCA-positive tumors in breast and other cancers. Pictured here is Angelina Jolie. She famously had a bilateral mastectomy after learning that she was BRCA positive, and 2 years later also had a hysterectomy and oophorectomy. So the National Comprehensive Cancer Network publishes guidelines to help inform clinicians about patients that may warrant further genetic risk assessment. And the criteria that they use include patients with a personal or family history of breast or ovarian cancer, patients who were diagnosed at an early age, patients diagnosed with triple-negative breast cancer at age 60 or younger, patients with a family history of pancreatic or prostate cancer, and patients with a second primary. I wanted to specifically highlight this criterion, breast cancer diagnosed at age less than 50, because this is updated in this year's guidelines that were just published in January. The prior version of the guidelines, which we used for our study, had this age cutoff at 45 or younger. So this means that with the new guidelines, there are potentially even more women that might benefit from BRCA testing. So this flowchart just illustrates the pathway to BRCA testing for patients at Emory and Grady. While there is nothing preventing a PCP from referring a patient for genetic counseling, currently medical or surgical oncologists are usually the ones who are doing it in our hospitals. So if the oncologist determines that the patient might be high risk, they can refer them for the genetic counseling appointment. And at that appointment, the genetic counselor will perform a thorough assessment, including a history and a pedigree, to determine whether or not they would recommend testing for that patient. So if the genetic counselor recommends testing and the patient consents, then the oncologist can order BRCA testing as a send-out lab. There have been previous studies looking at the rate of BRCA testing among women diagnosed with breast cancer. There was a retrospective cohort study of women diagnosed with invasive breast cancer in 2007 that found only 53% of women who were deemed high risk by the NCCN criteria were actually getting recommended for testing by their oncologist. And then another study that was looking at women who were less than 40 diagnosed with breast cancer between 2006 and 2014 found that there was an increasing rate of BRCA testing among this group, but the cohorts of both of these studies and most other studies are comprised of predominantly white women and women with private insurance, not really reflective of our Grady population. So the purpose of our study was to compare the rates of BRCA testing among women with breast cancer at Grady Memorial Hospital versus Emory University Hospital. And we also wanted to determine any factors associated with or predictive of the difference in testing. We included all women who were seen at either hospital between 2010 and 2014, and who were diagnosed with breast cancer between the ages of 20 and 70. We performed a retrospective chart review using a data set from the Georgia Tumor Registry, included just under 1,000 cases in our final analysis. We looked at patients' age, race, insurance status, type of insurance, and as a proxy for socioeconomic status, we used the mean and median household income of the patient's residence, the zip code of the patient's residence. We reviewed the records for referral to genetic counseling, whether the testing was performed, and what those results were. And then we performed univariate analysis and multivariable logistic regression on that data set. We risk stratified the patients based on the NCCN criteria I mentioned before, and we defined a high-risk patient as one who met at least one of these criteria. This concert diagram just shows how we got to the patients included in our final analysis. We excluded about 19% of Emory patients and 12% of Grady patients, largely due to being diagnosed at an outside hospital, being diagnosed outside the years specified, or having incomplete data. So comparing the demographics of patients at Emory and Grady, we see that Emory patients live in zip codes with higher income. We see that the majority of Grady patients are African American, whereas the majority of Emory patients are white. And we see that most of the Emory patients have private insurance, whereas the Grady patients mostly have Medicaid or are uninsured. The univariate analysis showed an increased rate of testing, as we would expect, among women diagnosed with breast cancer at age 45 or younger, women diagnosed with triple-negative breast cancer at age 60 or younger, women who were deemed high risk by our criteria, and women with triple-negative breast cancer. The analysis also showed increased testing rates among white women, women at Emory, women with higher incomes, and women with private insurance. And you can see that this difference is often as much as twice as much for the white women compared to black women at Emory compared to Grady, and higher income versus lower income. The univariate analysis also showed an increased rate of referral for genetic counseling and testing. And this was a difference that persisted when isolating both for a group of high-risk patients and also for a group of low-risk patients. And you can see among all these groups in the high-risk cohort, patients at Grady, African-American patients, and patients with lower incomes who are high-risk are getting referred less than half of the time. The multivariate logistic regression showed increased odds of referral to counseling among women at Emory, white women, and high-risk women. The regression also showed increased odds of undergoing testing for women at Emory, white women, and high-risk women, as stated before. And you can see that these odds ratios are around 2 for women at Emory and white women versus their counterparts. So, in conclusion, our study showed that there are both hospital and race-related disparities in both the rates of genetic counseling referrals and BRCA testing. And this is happening even though we have Emory-based faculty at both of our hospitals, and sometimes even the same faculty member at both hospitals. We also see that low-income and underinsured patients are less likely to be referred for genetic counseling and testing. And even though we have a higher proportion of high-risk patients at Grady, it seems that there are some definite logistical and financial barriers that are preventing them from getting the counseling and testing that they need. So what can we do to improve these disparities? One idea may be to implement EMR prompts or use dot phrases to help encourage providers to uniformly enforce the criteria for genetic counseling referral. But the most important thing is that whatever we do, we need to adapt these interventions to accommodate our patients at Grady who are in a resource-limited environment. For example, even if you were to refer a Grady patient for genetic counseling, they may not even make it to that appointment because that requires an additional copay, additional transportation costs, and additional time off work. So future studies should really investigate the effectiveness of interventions like these at reducing the disparity. These are my references. I wanted to thank everyone, particularly everyone who helped me with this study, my research mentor, Dr. Goganini, Tor Sauter, who graduated from Emory Medical School last year and was very helpful with data collection, and Dr. Zhang and Chen, our biostatisticians. Thank you.
All right, and then last but not least, and thank you for your patience, Natalie, we have Natalie Giles. She's a PGY3 in our program. She's moving on to an academic hospital medicine position in DC very soon, and we will miss her. And she is presenting on building a better discharge summary to improve transitions of care at hospital discharge. That's not you. NG and NG. Okay. We have two. I'm getting it, guys. Okay, here we go. Thank you, Natalie.
All right, thank you, everyone. I'm excited to be here to present to you all my quality improvement project, building a better discharge summary to improve patient transitions at hospital discharge. No disclosures. Just some background information. So discharge summaries, we know, are a very important role in patient care transitions, and unfortunately are often the primary or only means of communication between inpatient and outpatient providers. And there's actual guidelines that you may or may not know from the 2009 Transitions of Care Consensus Conference that created a list. There's the different societies from hospital medicine met together and created 20 criteria that they recommended to be included in discharge summaries. And they found out that discharge summaries are often not standardized, and many a time they lack these important criteria, a lot of which you may be familiar with, such as tests to follow up on, the consultants that were involved, the medication reconciliation, but may not have known that these are actual guidelines for this. And additionally, the American College of Physicians recommended that primary care physicians be involved in creating a discharge summary, since they are often the primary recipient of this discharge summary. So our aim statement for our quality improvement project was to improve the Emory discharge summary template, specifically the Power Note template, because there were some changes with the former Power Note that we wanted to make. And we wanted to incorporate the consensus criteria and also include the needs of the primary care providers. And we had an ambitious goal to include this in 100% of Power Note discharge summaries by the end of 2017. So before our intervention, we did two phases in our project, a qualitative analysis and a quantitative analysis. For a qualitative analysis, we surveyed the primary care providers to assess their needs and the different components of the discharge summaries. And then we created a fishbone analysis to stratify the different areas that we could improve their satisfaction. For our quantitative analysis, we did a chart review of 100 discharge summaries. And this included discharge summaries across all Emory sites, and also of note included discharge summaries from across all specialties, not just hospital medicine. And we evaluated their use of all 20 of the Transitions of Care Consensus Conference criteria. And we were exempt from this project from the Emory IRB. So going to our fishbone analysis, we found a few things to work on with the old Power Note discharge summary. So number one being follow-up appointments. Often these were not included, so the primary care provider would not know which upcoming subspecialty appointments that the patient would need to go to. They're either not listed or they were incomplete. The next important thing was the medication reconciliation. With the old Power Note template, it was near impossible to import the medication reconciliation completed, which was, as you can see, is very problematic from a primary care perspective, not knowing which meds were changed in the final list of medications. Also, home health orders was another important issue that the primary care providers wanted to include. They didn't know if there were any needs that their patient had after discharge. And also important were pending tests that were lingering that needed to be followed up on. Often these weren't included. And then in addition to the content, the discharge summary style and organization was another area to focus on. With the old template, it incorporated a bunch of lists of different labs and different radiology reports and did not include important information at the top of the discharge summary. So we created the new PowerNote discharge template. As you can see, in the red box, there's a follow-up appointments towards the top, as well as follow-up test recommendations. We also included discharge medications and home health follow-up items to be included. So after we created the new discharge summary, we did a subsequent qualitative analysis where we resurveyed the primary care providers to assess for improvement in their satisfaction. And then we did another chart review of another 100 discharge summaries to assess if for increased usage of the discharge criteria. And we compared from the before the new and the after. And we used a 2-sample t-test to calculate p-values. So for our primary care survey, our qualitative analysis across the board, primary care providers either strongly agreed or somewhat agreed, all agreed that there was improvement with the new PowerNote summary. And then for our qualitative analysis, we looked at all 20 criteria, but we decided to focus on these 3 since they were the most important expressed from the primary care perspective. So number 1 being medications. You can see a 72% increase in the medication incorporation of the MedRec into the discharge summary. And then also the follow-up appointments increased from 75% to 93%. And the recommendations at follow-up from 25% to 29%. And on average, across all subspecialties, increased usage of the content from 11 out of 20 to 14 out of 20 criteria. So this is some new data that we're starting to look at because ultimately we hope that this improves coordination of care between inpatient and outpatient, and we would like to see some improvement for the patients themselves. So we're starting to see a trend towards decreased readmission rates. This is specific data for Emory Midtown Hospital, but we're just now starting to look at this data, and we need a few more data points to keep on going. So some limitations of the study. The survey that we sent out, it was 3 months after the new discharge summary rolled out, but it was, not very many of the primary care providers had seen the new discharge summary in their follow-up, only about a third, and so we only had 11 respondents, but we're working on that. And for our chart review, we only changed the PowerNote template, but as we know, different providers have different preferences. They use dictation, they use dynamic doc. So we might have our results might be actually underrepresentation since we actually reviewed charts with those other formats. Some conclusions. So there was definitely some dissatisfaction between the primary care providers with the old template, and we saw a significant improvement with our new template, and they all agreed it was definitely an improvement. For our qualitative analysis, there was a lot of consensus criteria that were lacking, and we're already seeing statistically significant improvement with inclusion of these recommended criteria. And we're on the track towards hoping to improve patient coordination and reduce readmissions. So we have a few future directions in our Transitions of Care Quality Improvement Project. We're reserving the primary care providers for this current project, and actually this project is serving as a model QI project for other healthcare systems. We're collaborating with UT Southwestern, University of Kentucky, Mississippi, University of Mississippi, as well as a few others, where so we'll have more data across multiple systems. Our goal is to identify best practices. And we're also creating a discharge hotline where patients can call actually to be in touch with the hospitalist that discharged them to also improve patient care. And we're working with different subacute rehabs to also better coordinate care of patients to be discharged to their facilities. My references. And I'd like to thank my mentors, Dr. Christopher O'Donnell and Dr. Holberg, as well as our wonderful medical student, Kristen Flint, for helping us with this project. Thank you for having me.
Okay, thank you, everyone. I think you can all agree that we had a really wonderful, beautiful representation of the depth and diversity of projects that our residents get involved in. And so we're really proud of the collaborations that our residents have put forth with our faculty. And in the interest of time, I'm sorry that we ran a little bit long. I know that our presenters would welcome feedback on their research, but I think if you have questions, just come down to the front so you can discuss this with them. And then I also invite everyone to linger with our poster presentation directly outside the Emory Auditorium with some light refreshments from now until about 2 o'clock. Thank you very much.